Well, good afternoon. I'm Dr. David Callender, president of UTMB, and I want to thank you all for coming. I have a little prepared statement I'd like to read here, and then happy to address your questions. We really appreciate your efforts to help us provide fact-based information about the evolving Ebola situation and UTMB's role in the effort. As you know, here at UTMB, we have some of the world's leading experts on infectious diseases, including Ebola. Our researchers and clinicians are routinely called upon for their deep knowledge of the virus and the disease. State leaders are well aware of UTMB's knowledge and experiences with diseases like Ebola and are calling on UTMB to stand ready, if necessary, to provide direct assistance in addressing Ebola infections and related medical waste and other products in Texas. We believe we are uniquely positioned to safely and effectively support this request. As you know, we've safely conducted biosafety level 4 research for 10 years with no infections among those who work in high containment labs. UTMB is home to the National Biocontainment Training Center, where scientists train to safely work in high containment research laboratories all over the globe. The training center also lends its expertise to UTMB's clinical staff, making sure that all safety protocols are in place. Of course, we always want to be ready. As a level 1 trauma center in Galveston, part of the greater Houston region, and located adjacent to a busy seaport, that means that UTMB's health system must always be prepared to handle any health emergency. Freighter vessels from all over the world or ports of call all over the world routinely come through the Port of Galveston. UTMB has been providing specialized training to its healthcare workers well before the first Ebola case was diagnosed in Texas. UTMB clinics have an adequate supply of personal protective equipment, and workers have been trained in the proper way to don and remove or doff the special medical gear. UTMB is highly experienced in safely destroying medical waste. For 10 years now, we have been handling safely and effectively more than 1,500 pounds of medical waste every day. At this time, we do not have any patients who have or are suspected to have Ebola infection. And at this time, we have not been asked to accept any Ebola patients from elsewhere. But if a patient does come to UTMB who is suspected of having the virus, I have every confidence that our staff is well prepared to provide quality care. Let me say just a few more things about that care. Our staff will not be asked to provide direct care unless they have received additional specialized training. Our students and residents will not be directly involved in caring for Ebola patients, although they will be trained on how to screen patients for the disease. If we do have a patient with Ebola infection, they will be treated in special isolation units that are apart from our main hospital facilities. I do understand there is a lot of fear and misinformation in the public about this disease. Please work with us to help get scientific, fact-based information out and to help ensure our community that we can safely and effectively respond to the state's request. Thank you, and I'm happy to take your questions.
Have you received any medical waste yet from the Dallas?
We have not.
No. Do you expect to?
Yes, we do. We were asked officially by the Texas Commission on Environmental Quality to render aid as a state agency. It turns out that we're really the only licensed medical waste incinerator in the state of Texas, or have an incinerator, that can capably and safely handle this waste in the way that it's been packaged. So we think it's our responsibility, given our mission, to make sure that we improve or safeguard health in Texas to do this, and we don't believe anybody can do it more safely than we can.
Do you have any sort of timetable or?
Not yet. We really.
What's going to happen?
No, we need to work out the agreements in terms of managing the waste, getting it here, making sure that it's appropriately cared for. We're not going to be responsible for transporting it. We will accept it when it's here, inspect it, make sure that it's intact, deal with it to make sure that it is can be managed safely, and then incinerate it.
Is there an agreement or an understanding with the state now that if someone suffering from Ebola is diagnosed in any hospital around the state, that they're going to be sent here?
No.
Doctor, about the incineration process and why folks should not be concerned.
Yeah, the incineration process involves taking the drums, which essentially are very thick cardboard and sealed with a steel band, placing them into an incinerator and heating immediately as soon as that drum is pushed into the incinerator, heating that drum to 1,500 degrees, which immediately incinerates it, reduces to ash, and destroys it. Now, any residue that rises from the ash goes into a separate chamber, which is heated to 1,800 degrees, which vaporizes anything else. The only thing that comes through are heavy metal residues in small quantity. Those are collected in the end of the process, basically formed into a pellet. So we have ash and heavy metals that can then safely be taken to a landfill. They're inert. They don't have any infective capacity. Ebola, typically, we don't know exactly how long it can survive out in a bodily fluid. What we believe from the experience in Africa is that once the body fluid is desiccated, goes dry, then the virus doesn't really have a possibility to survive. Our scientists believe, again, on that previous experience, that Ebola might survive for up to 4 days at most on a surface. And so this material has been sitting, it's solid waste, it's not liquid waste that's been disposed of in another way. This solid waste has been sitting on a truck for more than 7 days now. So the likelihood that it could harbor any infective material is very low. And the process used to collect it, to sterilize each of the bags that's contained within the drum, there's a bag within a biosafety container, another bag, and then into the drum with everything disinfected between each bagging, not likely to allow any viable virus. We think there's no chance.
What about any treatments or vaccines? Where do those stand now as far as your research and getting those into production? What are the greatest challenges you're facing?
Well, let me call on Dr. Thomas Geisbert. He is one of the faculty members in our Galveston National Laboratory. He's one of the leaders in the country and the world in terms of research, and particularly relative to research on therapies and vaccines. He's been working on this since his time with USAMRIID and the time in the Army, so he's really the expert. Let me let him talk about that. Dr. Geisbert?
Thank you. There's been a lot of progress in the last 5 to 10 years, and it's because of facilities like we have here at UTMB and the Galveston National Laboratory. After 9/11, the federal government recognized that there was a need for countermeasures, medical countermeasures against Ebola and Marburg viruses, and it was that process that led to funds for this particular facility here, a facility at RML, and I will say the state of Texas also contributed substantially to this facility. So with the increase in research on Ebola and Marburg, there have been quite a few different vaccines and treatments. As of yesterday, I'm aware of 3 different vaccines. These are preventive vaccines. If you're familiar with like measles, mumps, rubella, like you get as a child, to prevent you from getting an infectious disease, that's what I'm talking about here when I say a preventive vaccine. So for Ebola, there are 3 now that are starting to enter phase 1 trials. 2 of them, I think, one started last week. One is actually started in Mali, I believe, and then one will start next year. 2 of these are based on a vaccine platform called vesicular stomatitis virus, or VSV. There's a company called Newlink Genetics, and then another company called Perfectus Biosciences. Both of them are going forward. And then the NIH has a vaccine with GlaxoSmithKline based on a chimpanzee adenovirus, and that's also going forward. So there's currently 3 vaccines that I'm aware of that are moving forward for phase 1 trials. Right now, there are 2 post-exposure treatments that have completely protected non-human primates, and that's important because to license a vaccine or a treatment, for Ebola, you have to fall under what we call the FDA animal rule. This is a rule that was put in place by the federal government in 2002 to deal with exotic pathogens like Ebola. And what that rule says, it's actually federal, it's part of the Federal Code of Regulations, so it's a law that we have to follow. You use animal data, so you have to show that your vaccine or treatment is protective in an relevant animal model, and then you also use conventional phase 1 clinical data, and that's just data showing that if I put this vaccine or treatment into a healthy human volunteer, that it does not cause disease. So right now, there are 2 post-exposure treatments that I'm aware of that can completely protect non-human primates against Ebola. after exposure, that's one of the requirements of that role. Those are ZMapp, which I think everybody is familiar with, and unfortunately the stocks have run out. And the other one is a drug called TKM Ebola from a company called Tecmera Pharmaceuticals. That was the particular drug that was used in Dr. Richard Sacra, who was in Nebraska, and it's been, I know of at least 3 other patients, so possibly 4 patients. So those are probably the 2 lead candidates. There are quite a few others being developed at the same time that I'm aware of. But you know, it's a process that while we use a drug, for example, under compassionate use, it's still, to get licensure, you still have to go through the process. So they're at various stages, and I think all of the vaccines we're looking at are sometime in 2015. Do you want to comment any further on that? Or?
Thank you very much.
The governor has called for a travel ban. Can you comment on whether that would work or be effective or is necessary?
Well, you know, I have to rely on our scientific experts here. And what they're telling me is they believe that actually a travel ban could have just the opposite effect. That what happens with travel ban is patients become, infected patients or exposed patients become concerned about providing an adequate history relative to their travel to West Africa or their travel from West Africa. They certainly still will want to come to this country. They will likely not tell the truth about their travel history, and they will find a way to get here, although it will be more of an indirect route. What seems to work is really good screening, be able to trace the patients, where they've come from, understand their travel history, and then be able to follow them if they come from a high-risk area. A travel ban then, as you see, might have just the opposite effect. We wouldn't know the origin of the patient's travel, and they might not tell us the truth about where they came from or what countries they have traveled to and from. And so therefore, the scientists believe that travel bans aren't particularly effective and can be harmful. So now there's a political side to that too, and I'm not qualified to comment on that one.
Is there any scientific basis for a travel ban doing any good in this situation? And if there's not, where do you think all this is coming from? Because that drumbeat seems to be getting louder over the last week or so.
Well, you know, we all think as humans. We try to process the information around us, and there's been a natural sort of desire approach we have as humans anytime an infectious disease breaks out to isolate people who might be infected from an uninfected population. And again, what our scientists tell me about the experience in Africa is that isolation approach typically hasn't worked with Ebola. One of our senior scientists, Dr. Tom Kizak, who was on the ground in Sierra Leone as part of the CDC deployment until just a few weeks ago, described this as, you know, if you build a 20-foot fence, somebody's going to build a 22-foot ladder. So they're going to figure a way to get around that isolation approach. And particularly with globalization of travel, people moving around the world, you know, it's very hard to keep people in one place. So again, the better approach, we think, is to understand the travel history, to screen the patients adequately, to follow them, and then should there be any suspicion that they might be developing the disease, then the isolation occurs.
Tom, can I ask you another question? Yes, sir. One of the things that we hear a lot from the public are just this vast difference that they have, seeing all of the imagery of some folks wearing level 1 suits, some folks wearing no protective gear, and knowing that in Africa and a lot of places they're dealing with this without even running water or truly gloves. So can you just talk to folks about transmission and the differences there and why we do the things that we do?
I actually think you want Tom Kizak to answer this. That's really more his field. Tom, can you take this one?
Well, in terms of protection, I think you have to take a realistic approach that, again, really the transmission comes from very close contact. And so if I'm an individual at a site where there's an Ebola patient and you're the patient, I'm safe over here from my perspective. And the history of way people have responded would bear that out. We're being, I guess, overly cautious. I think there's a fair amount of hysteria that somehow works its way into the situation, and so we raise the level, which I'm not sure sends the right message to the American people about the real practicality of this. I mean, I think everybody wants to be safe, but I think you have to look very hard at the science and adhere to that rather than just taking it continually to the next level. And unfortunately, I think that happens sometimes. We have the resources to provide those levels of protection, but the practicality of it in Africa, they don't. I think that it's quite clear that there are levels that are significantly less than we often employ that are quite safe. Does that answer your question?
Can I ask you a question? Drexel University this morning said that perhaps the 21-day incubation period was not long enough, that was based on CDC's findings of the Zaire outbreak in '76, and they say the current outbreak data indicates maybe 31 days is more appropriate for an incubation period. What do you say?
Do you have any data that they provided along with that?
Drexel University put that out. That's what they're saying, that the 21 days was based on old data.
Yeah, there are a couple days that get kicked around. 21 days, in my estimation, is long enough. The practical incubation, if you look at the means, et cetera, you can find scientific papers where that's discussed. It's well within the limits of 21 days and the statistical outliers of it. Another date is twice 21 days, 42 days, that has been used to absolutely declare a country free. And that's done not for the reason that someone believes the incubation period is that long. It's really to allow some other cases perhaps to have undergone and sort of be beneath the surface and then allow them to be seen. So 42 days is often used as the limits for declaring the outbreak absolutely over.
Do you know of any cases where the disease presented itself after 21 days of infection?
Absolutely not.
Dr. Kaiser, we've talked a little bit about infection. I'm curious, though, about what your thoughts are on some of the misinformation that's out there, some of the assumptions that the general public makes about how easy it is to catch Ebola. What would you want folks to take away from this today? What would you like them to know about their own safety?
Well, I think, again, you have to sort of look to the practical situations in Africa where, unfortunately, these outbreaks have been relatively common and what the circumstances are around transmission and some of the studies that have actually been done under those circumstances to show what's dangerous and what's not. And the real risk factors, again, that constantly emerge in whatever studies are done are that direct contact, and that can be redefined perhaps because the issue of aerosol versus droplets is something that's a little bit different. I think of an aerosol as creating something that sort of wafts through the air and flies over there where Dr. Leduc is sitting, and droplets, on the other hand, if I sneeze or cough, I'm creating these large droplets that fall out very quickly. If you're in the line of fire, I can hit you in the eye with it, and that is an infectious dose that I've just administered to you by projecting that particle directly onto your mucous membranes. But sort of outside of those parameters, I don't know of any patients that have. The other risk factors are burials. The bodies remain quite infectious. I think that there are ritual funereal practices that in Africa have played a large role in transmission. We largely don't suffer those sorts of things. The recommendations for handling bodies from patients here in the U.S. are quite different. They're pretty strict and they understand the infectious process.
So do you think people are overreacting?
Well, from what I see in the press, yes. I can't help but personally feel that, there's a lot of overreaction. I'm not sure what the source of the information that leads people to be so fearful of a circumstance that I think the scientists at the CDC and other public health agencies have tried to be clear about.
I had a doctor tell me yesterday that he really thinks that the last 2 weeks, the next several weeks, we're going to have the ability to learn more about Ebola than we have since we've known about Ebola. with it being in the first world and the experience in Africa combined.
That's true.
Well, what I really hope is that we have no more opportunity. Here in this first world.
This morning, the head of the Texas Task Force, Governor Kerry's Infectious Disease Task Force, said he wanted UTMB to be a designated hospital for Ebola treatment. What capacity right now does UTMB have to treat Ebola patients? I know there are no coming, but how many Ebola patients could come, and how many people are trained right now to handle those patients?
Yeah, thank you. I actually just concluded a meeting with our staff members where we talked about this. And as I mentioned, we have an active international seaport here. We have a level 1 trauma center that serves the greater Houston region, extending offshore to offshore installations. So we feel as if we need to be prepared today. So, and of course, associated with the national lab, we have to be able to handle an occupational exposure should one of our researchers become infected, not only with Ebola, but another highly transmissible infectious disease. And so we have been able to care for an occupational exposure for some time. We are prepared now to care for a patient identified within our system. So if a patient presented to one of our emergency centers, presented to one of our clinics, presented to one of our urgent care centers, we have the ability to identify that patient, get the appropriate history, institute immediate isolation measures, have the tools to safely transport the patient, bring them here, put them in one of the 3 isolation rooms that we've identified, which is separate from the main hospital off of our emergency room. We have 32 nurses who have volunteered and been trained to be the primary caregivers. A number of our infectious disease and critical care faculty members also have been volunteered and been trained to be in the room with the patient. From our perspective, there would be no need for any others to be in direct contact in the room. We plan to be able to provide support, including laboratory testing, at those sites so we don't have to transmit specimens to other areas of our campus. So we've done extensive planning, thinking not only about how we identify patients, but how we safely move them to an ultimate site for care and then safely deliver care in a way that protects our healthcare providers as well as the patient.
Just to follow up, you said you're prepared for patients inside the UTMB system. What about patients coming from outside the system, from other hospitals or?
The task force has made this recommendation. We've been visited by a number of state officials over the past several weeks who have asked about what's your ability to do this, what would this look like, enhancements to facilities and capabilities. And so I understand the governor, based on the recommendations, early recommendations of his task force on infectious disease, has said UTMB has incredible expertise. They know more as a group than just about anybody in the state about these diseases, about what's required to take care of them. It makes sense that we ask them to be among the first designated centers. And now what he's asking us to do is to work with those state officials, Dr. Kyle Janik, who is Executive Commissioner for the Health and Human Services Commission, Dr. David Lakey, who is Commissioner for the Department of State Health Services, to think about, okay, what does that function really look like? How could we develop that function? When could it be ready? And so we just have to begin those conversations. This is really for the longer term. What does our state need to do to be ready, not only for Ebola, but other emerging infectious diseases? And unfortunately, our faculty, Dr. Leduc, Dr. Kizak, Dr. Geisberg, can identify a tremendous number that are out there looming just as significantly as Ebola.
Doctor, I have a question about survival rate. We've heard on this outbreak somewhere between 50 and 70% actually don't make it with Ebola. Let's talk practically, though. The people who have, say, Americans who have been treated from Western medicine, what would you say their survival rate is?
Well, we really don't have enough data to really, for me at least, to be comfortable saying, okay, our survival rate is this. Dr. Kizak, and he may want to come back up, will tell you that the current survival rate for Ebola Zaire in this Western African outbreak, we believe, is about 70%. We don't really have good data because there are not good tracking systems in those three primarily affected countries, but that's the CDC's and World Health Organization's best estimate. You think about the small number of patients that have been treated in this country, Americans, we've brought back. The one patient who came from West Africa, only one has died. What's the reason for that? Is it because we have a greater capability with interventions? We can support those patients better? Is it because of ZMAP? What are the reasons? So our approach, our capability here is different. We think it can make a difference, the way we treat patients. That's our hypothesis, and we're going to proceed on the basis of that until we have more information about the disease.
So the person who passed away you're talking about is Mr. Duncan?
Mr. Duncan.
Okay. And how many others have you treated? How many are out of the hospital?
It's those healthcare workers that have come back, so Dr. Brantley and that first nurse. We have the camera person who's here now. We just have the two new identified cases, the nurses that have been transferred from Texas Presbyterian to the NIH and to Emory. So again, we're gathering that information. We don't have any information one way or another basically to suggest that the more intensive care measures, interventions we can provide here won't work. So I think that the general approach across the country is to use what we know. This disease looks a bit like septicemic shock or septic shock in terms of the way it manifests in advanced states of the disease. And when other patients present with septic shock from other causes, we treat them aggressively.
I'm trying to give you an opportunity to tell people that here in the United States, their survival rate is much, much greater. You're not willing to go there.
That's our hypothesis. That's what we believe. But again, we're scientists, or I'm a physician, but supported by a lot of scientists. Before we step out and make absolute statements, we really need data. So we're guided by hypothetical approaches based on what we've done before in similar circumstances. But, and again, this is part of working to control hysteria. Be very clear about what we're doing, the basis for the decisions we're making, and then gather the data and report it very adequately, report it very transparently, and so that's what we're all trying to do. So thank you for the opportunity, but this is the way we work.
You have 3 rooms, you said you have 3 rooms. Does that mean you could take 3 patients now? And if so, why were those 2 nurses sent other places?
Well, our preference actually right now, again, our focus is on treating patients that we identify within our system. And so we would bring those patients in, we would institute our protocol, start our care measures, talk with Dr. Lakey's people, his staff, and talk about, okay, how do we manage this patient? Do you want us to leave them here and provide care? Are you still in the mode of thinking about transferring them to the other identified centers? And again, these are ongoing points for discussion right now. We're not really ready or prepared. We don't have a desire to take patients from other places right now, but like any other major hospital in this state, we need to be prepared to take in patients, provide adequate care, work with our state authorities to decide what's best for everybody at this point.
But you could take 3, you have 3 rooms.
We have 3 rooms. Yes, sir.
If I may follow up, the governor's task force report today recommended UTMB as the center in Texas. It's the only one they mentioned. So I'm sure you're aware of that.
Yes.
That there is an intent down the road that if they get more Ebola patients in the state, they're going to come here.
That is, and again, what the governor's, my understanding, at least the governor's directive to us, is to work with Dr. Janet, Dr. Janik, Dr. Lakey, and others to establish that capability for the future. What does that really mean? How do we safely transport patients from around the state? We know how to move them within our system extraordinarily well. We know what's been done on an ad hoc basis with these patients being moved from Dallas. But what is the regional transport system? Who goes where? What support comes from CDC, from Austin? All of those things need to be worked out. Are there any facility enhancements that are necessary or that should be considered to be absolutely state-of-the-art, world-class? So what the governor's really asked us to do is think about what that looks like, and let's all work together to make sure we have that capacity as quickly as we can.
What do you think the time envelope would be between?
To be developed. I don't want to speculate today. Again, my concern today is if somebody walks into our emergency room coming off a cruise ship or a freighter, somebody comes in who's traveled to West Africa, who came from Houston Airport, that we could provide safe and adequate care.
Cruise ship coming in.
You know, I'm not really sure.
We heard it just got, Cozumel turned it away, so it's coming back.
Yeah, and
To show up and address that patient or something?
no. Again, this is a state issue, so the State Department of Health Services and the CDC are involved. If we're asked to assist, we're certainly happy to do that, but our current understanding is what they're thinking about is where that patient would be transported, again, to one of these other identified centers that's currently being used. Now, should we be ready? Absolutely. It would be, just like I said in our employee meeting, what's the difference between someone they've already identified walking into our emergency room or being brought to it versus a patient who's walking off of that cruise ship who suddenly reveals they have the travel history and has symptoms?
But wouldn't it make sense if potentially that was an Ebola patient to take them as quickly as possible to the closest hospital?
Sure, absolutely. Yeah. So what does that look like? Again, these are state public health system questions. And so I can answer relative to our capabilities and what we're prepared to do, but I can't really speak for the state, for Dr. Lakey and Dr. Janik. So I think we need to involve them in answering those questions too to be totally accurate.
You haven't been asked to get the beds ready today?
No, we have not been asked to get the beds ready. So.
Contacted by some parents at a school district in the area. Apparently there's a local teacher who's over in East Africa. You as scientists, do you have any concerns about that teacher coming back? Apparently they have told that teacher there to take a little bit of time off from class for 21 days.
Yeah, Tanzania is about 3,000 miles, I think, away from the areas where the outbreak is occurring. And so, it's not what I would have advised the school system. But again, they're thinking about this from the perspective of absolute safety for their students. And so that's really their decision. But from a disease control perspective, it's not something that's really necessary.
Thank you, everybody.
Thank you, guys.
UTMB Health, working together to work wonders.